The number one fear women have before starting menopausal hormone therapy is an increased risk of breast cancer. And as doctors, we're alarmed too. So today, I'm going to break down the science. We're going to review the research from the Women's Health Initiative and your research to discuss what the evidence shows. Specifically, we're going to talk about what endogenous hormone, what estrogen does in our bodies, and how that compares and contrasts with exogenous estrogen in pill form. We'll briefly review the data from the Women's Health Initiative in terms of breast cancer incidence. We'll also include newer research. Also, we'll talk about individual risk and how age and family history and other factors play a role. And then finally, I'm going to pull it all together for it to make sense to you. So let's start with the basics. Who is menopausal hormone therapy safe for? Menopausal hormone therapy is safe for healthy women who are symptomatic and near menopause. They're under the age of 60 or within 10 years. Who is it not for? Anyone who has contraindications or reasons that as doctors we would exclude a patient from a certain test, procedure, or treatment. Contraindications include having breast cancer, but other contraindications such as having liver disease or clotting disease, blood clots need to be discussed with a doctor. As we've discussed before, long-term use of menopausal hormone therapy solely for the prevention of chronic medical diseases is no longer a thing. What we're going to do is we're going to go back to how estrogen acts within our bodies to try to better understand the risks and the concerns behind breast cancer. Let's start with a very simple point. The longer a woman is exposed to estrogen, the greater her risk for developing breast cancer. I want you to remember that because that is the simple biologic principle. What kinds of conditions can expose a woman to a longer duration of estrogen? Well, having an early period, having a late menopause, having a low number of births or no births, what we call nulliparity, having a higher bone density, which is a marker of a lifetime exposure of more estrogen, and then having a higher body mass index or BMI, because estrogen can be produced peripherally in fat tissues. These patterns suggest a simple biologic principle that estrogen stimulates breast tissue, and with more stimulation comes more breast cancer risk. This is why exogenous hormone therapy was always assumed to increase the breast cancer risk. Of course, people are alarmed that if you give a woman estrogen, you would increase her risk. It just came down to how much could you give at how fast a rate and what specific circumstances limited that. The epidemiologic data before the Women's Health Initiative was sparse and mainly observational, and they were prescribing estrogen for so many things that to prevent a variety of diseases that we had quite a bit of evidence, but it was observational. One example from 1997 included a meta-analysis of over 50 studies that found that breast cancer risk did increase by roughly 2.3% for every year of menopausal hormone therapy use. Back then, many women were on oral conjugated equine estrogen and synthetic progestins like medroxyprogesterone acetate. We're going to come back to the formulations. So this set the stage for the Women's Health Initiative data. In that particular study, the Women's Health Initiative was the first large randomized trial that answered two basic questions. Number one, what was the effect of estrogen and progestin? And number two, how did that effect compare with regimens of just estrogen alone? The Women's Health Initiative found that women on combined therapy had a 20% relative increase in invasive breast cancer over a median of 5.6 years. The risk appeared sooner by year 3 in women who were previously exposed to hormones. In women who were on estrogen alone, there was no increase in breast cancer during the intervention phase, and over 13 years of follow-up, they found that there was actually a 21% lower risk of breast cancer. Remember this point because we're going to come back to that too. Newer studies actually challenge it. This doesn't necessarily mean that estrogen alone was preventing breast cancer risk. Remember, these are observational studies. Today's regimens are very different. They're often using lower doses of estrogen that are topical, such as vaginal estrogen or transdermal. We're using natural progestins instead of the synthetic kinds that were used before the Women's Health Initiative. What is the rule of women in their 50s? Doctors love to quote that for women in their 50s on combined estrogen and progestin therapy for 5 years, have an additional 3 cases of breast cancer per 1,000 women. And for women using estrogen alone, they have 2.5 fewer cases per 1,000 women. So this is why guidelines state that as long as the estrogen hormone therapy is limited for a short period of time, the risk of developing breast cancer is very low. How do mammograms play a role? Well, it's long been known that estrogen exposure leads to an increase in breast density, and mammograms become difficult to interpret, leading to more biopsies. Combined therapy was found to show a 5% increase in breast density, and estrogen only increased it by 3%. Combined therapy also increased abnormal mammogram and biopsy rates. That's why a lot of women end up having to get an ultrasound after their mammogram, just because the mammogram was too difficult to interpret. Briefly stopping the menopausal hormone therapy did not make a difference. What about duration? What is the risk of breast cancer? Well, as long as it's under 4 to 5 years, the risk is minimal. But as you go above 5 years, 10 years, the risk does increase. For estrogen alone, the Women's Health Initiative data showed no increased risk. But longer-term observational and newer studies, like the Nurses' Health Study, did show an increased risk over 15 to 20 years. So the duration and the formulation both matter. What are the roles of progestins? Not all progestins behave the same. In previous videos, I've discussed 2 types of progestins. We've got the synthetic medroxyprogesterone acetate, MPA, and then we have the natural micronized progestin. The synthetics were used largely before the Women's Health Initiative, and that's been associated with an increased risk of breast cancer. The micronized progesterone, our natural, does not appear to increase the risk in observational studies, but it is still being studied in ongoing research. This is one reason why modern menopausal hormone therapy does often use estradiol combined with a micronized progesterone. They're not using the conjugated equine estrogen and the MPAs from the past. Other factors that can modify a woman's risk while on menopausal hormone therapy include having a family history. The risk does go up. Drinking alcohol. Alcohol use by itself does increase the risk of breast cancer. A woman who drinks 1.5 alcoholic drinks or more per day will have a greater risk while on menopausal hormone therapy than either risk alone. Other factors include race. There are no differences between African American women and Caucasian women. And then finally, testosterone use. There's limited studies, limited research on this particular point. Women who are on a little bit of testosterone for their menopausal hormone therapy don't appear to have an increased risk, but again, the research is still very limited. Which women should avoid menopausal hormone therapy? Well, this is simple. A woman with breast cancer. There's a study called Habits that included women with breast cancer, and they found that those women who were given menopausal hormone therapy had a 2.4% recurrence rate, a return of their breast cancer. So usually these women are not offered menopausal hormone therapy, at least in systemic or oral form. Local options might be a consideration depending on discussions with their doctor. BRCA1 and 2 carriers of the gene BRCA1, 2, after risk-reducing surgery, they're also probably recommended or pushed to pursue non-hormonal therapies for treatments of menopausal symptoms. So here are our key takeaways. Short-term menopausal hormone therapy carries a very low absolute risk of breast cancer. Estrogen-only therapy showed no increase in the Women's Health Initiative trial for up to 6 years. Longer duration, higher doses in synthetic progestins like medroxyprogesterone acetate increase the risk. Alcohol use, mammographic density, family history all modify the risk. Women with a personal history of breast cancer should avoid systemic or oral estrogen and menopausal hormone therapy. Ultimately, menopausal hormone therapy decisions are going to be made between you and your doctor after a shared decision-making process. Your doctor and you will discuss your family history, personal history, social factors, cholesterol, other medical problems, and reach a conclusion that is safest for you. If you like this content, don't forget to give me a thumbs up and subscribe. I'm here to make the medicine make sense. Until next time.